So welcome everyone. It's my pleasure to get us started today, as we'll be sharing a specific use case where direct messaging was critical to automating data exchange between emergency medical services, EMS agencies, and the hospitals where they deliver their patients. My name is Alan Swenson, and I am the Vice President of Interoperability at Kno2, where our focus is on improving interoperability across the entire continuum of care. I oversee specific projects aimed to extend interoperability into hard-to-reach markets and groups that were not previously part of government incentive programs to drive interoperability, such as LTPAC, behavioral health, vision, therapies, and of course, emergency medical services that we'll be talking about today, among many others. I represent our partners and customers in industry trade associations and other industry interoperability initiatives, such as Care Equality, Commonwealth, Direct Trust, and serve in various leadership, committee chair, board of directors, and other positions across all of those initiatives. Prior to joining the Kno2 team a few years back, I was at Epic, where I led many of these same types of interoperability initiatives, particularly with Care Equality and Direct Trust. And I mention that in the context of this webinar, because many of the groups that we have connected with for the same flows that we'll be discussing today are Epic customers. So my background and familiarity with the system has been helpful. And in many cases, these are organizations that I used to support and work with from the Epic side, and now continue working with from the Kno2 and EMS agency side. So it has definitely been exciting to see the impact on both sides of this exchange and the improvements this interoperable flow of data makes for the EMS agencies, for the hospitals, and ultimately for the patients in improved coordination of care. Now with that, we'll continue some introductions of the rest of us on the team here. And next up is Dane Moyler.
Hey, Alan, thank you for that, and do appreciate the ability to participate in this today. I'm one of the co-founders of Kno2. That was in 2009, and the focus on interoperability has been to make it so that it's affordable, not cost prohibitive to all of healthcare, including the EMS agencies that we'll talk about today, because really interoperability ought to be available to everyone. My role at Kno2 is as the Senior Vice President of Business Development, and I work with key partners that are within our organization and that we partner with, as well as key connectivity and initiatives like we're going to see with the one today between Carilion Clinic and the EMS agencies that transport patients to them. I'll hand it off to Michael at this point.
All right, thanks, Dane. Hi, everyone. I'm Michael Paddock. I'm the Vice President of Product Management here at ImageTrend. So I've been at ImageTrend for about 20 years, and that's just about as long as I've been in the software industry. With ImageTrend, majority of my time is spent working with all of our products in public safety and healthcare. But in the last couple of years, I've really been focused on our interoperability and really sharing data between our pre-hospital documentation system, or ePCR as it's called, and hospital systems. So I'm really excited today to talk about it and share this case study with all of you that explains just that, of how easy it can be. With that being said, I'll turn it over to Tiffany and let her introduce herself.
Hi, my name is Tiffany Moran. I began my career here with Roanoke Fire EMS about 7 years ago. Prior to that, I worked with Roanoke Police Department for the past 15 years doing the same sort of job as automation coordinator. I work closely with the state police. I work closely with the state of Virginia Office of EMS to ensure that we remain in compliance with the accuracy and timely submission of our patient care reports. I also handle all of the technology needs ranging from phones, mobile computers, software administration, and integration. I am the system administrator for our ImageTrend Elite system, which is our primary fire and EMS records management system. And I guess I'll start by saying there were several challenges that we at Roanoke Fire EMS Agency dealt with, as well as the surrounding agencies that we were faced with. The biggest challenge was paper. There was lots and lots of paper copies everywhere. This was a very manual step. There was no automation and a lot of little steps along the way. It's a responsibility of each agency to ensure that the hospital received copies of each report. So once we finished writing a report at the hospital, we would connect our computers to the printers at the hospital. We would print a copy and then leave it in a specific location at the hospital. This led to lots of misplaced documents. Sometimes the printed reports were handed over to nurses, doctors, they were left in the wrong location. Sometimes the printer was down and they couldn't leave a copy at all, or they ended up having to leave for the next run before they could actually print out a copy and leave it for the hospital. This led to a lot of misplaced documents. Sometimes the printer reports never made it there at all. Sometimes they were in the right location, but because of the volume that we were doing, they ended up getting misplaced along the way. If for some reason the hospital did not have a copy of that report, they would contact our administration department and they would request that we fax it over. At the time, we were having to print a copy of the patient care report out of ImageTrend, so we could then fax a copy over to the hospital, and then we would have to shred that copy. So a lot of redundancy and a lot of little steps along the way. This led to more paper being consumed, but more importantly, it led to delays with the hospital getting the patient information and notes from the field personnel. Paper and cartridges and the upkeep of remote printers added to our cost, as well as manually chasing down reports. We were functioning, but not nearly as efficiently as we could have been. And at this point, Michael, from ImageTrend, I'm going to pass it back over to you.
All right, thanks, Tiffany. So what Tiffany was mentioning is all the things that happen prior to this. So a lot of paper, a lot of manual processes. So when we think about the solution and talk about that, what we really wanted to do was simplify it, right, and automate it so that you didn't have to deal with those types of things. So when you think about the solution, like I mentioned before, EMS is doing their documentation within an ePCR. So what we did was automate that of being able to export that data out of an ePCR, and then using the direct standard, securely transfer that information directly to the hospital. So we're transforming that EMS message into a message that can be consumable by the hospital using secure direct messaging. So once that data package is packaged up, then transferred over to the hospital, within Epic, they're using patient matching, and we'll get into the specifics of this later, but using patient matching to then automatically ingest that into the AHR and patient charts. So now you see from the standpoint of automating it, using all of these standards and reducing the need to handle with paper or faxes or different things of that nature to automate it as well. So thinking about it as a holistic solution to automate that, obviously better and a step forward than what we were previously doing. So we'll get into more details of this later, but that's kind of the high level solution of taking that manual step and automating that process. So how is one of those questions about how did we go about doing this? Well, one thing is using standards, and standards that are out there already, standards that are already embedded into EHRs, and that's really direct secure messaging. So typically in the past, dealing with HL7 v2 messages and dealing with all the things that go along with that of VPNs, we're able to just utilize these standards going forward. So thinking about bringing EMS into this holistic picture too, right? So getting them up to speed and connecting those systems together for pre-hospital to hospital. Again, just using these standards that are available. Again, not going through having to do the VPNs or HL7 configuration messages, utilizes that and streamlines that messaging process of getting up and running sooner. We'll also kind of talk about how we're expanding that even further and using another standard out there and using the carrier quality interoperability framework to expand that data sharing between pre-hospital and hospital folks as well, when you think about getting more information into the hands of medics that are treating patients out in the field. So what we wanted to do is really focus on connectivity and how easy it is, and it's really using these standards and really flipping those switches in both systems to say the interoperability framework is there. Let's leverage these. So when we think about the case study, and this is, you know, the cool part of it, of going through this process and to be able to share this with you today, is really walking through what Carilion Clinic did and how they worked with their surrounding EMS agencies that were using image trends ePCR to be able to connect that information together. And why this is such a great story is for a number of key aspects. One, it's scalable, it's repeatable, and it's really simple and affordable for using these standards that are already in place. Like I mentioned before, it's reusing this existing technology that is there already. Let's leverage that. So to get into more details, what I'm going to do is hand this off, the presentation off to Dane from No2 as he walks through the specifics of the project.
I'm standing in really for Walt Fisher from Carilion Clinic. And so I'll do hopefully a good job for him. Due to the COVID crisis, Walt's been obviously busy. So being able to provide this information to you is actually coming from a presentation that Walt did for the Epic Users Group. And they're very proud of this information and being able to talk about this solution. And if you relate to what their goal was, is really to create this connectivity to the entire community. EMS is what we're going to feature today, but it's being able to create this better interaction between themselves and the providers in the community and exchange the information so clinicians have what they need when they need it. And Carilion has been very forward about this commitment regarding this connectivity to all their providers. I think we can all relate to this depending on your personal experiences. But we don't like the fact that as a patient, when we have to communicate the information to multiple people, even in the same care setting, let alone in separate care settings, and having to do that for meds and allergies and our problems. And we really want to make sure that the person who's treating us at this moment, they have the most up-to-date information possible. And can you think of a situation more important than an EMS emergency care situation when they're tending to you as a patient, and you want them to be able to have all that information available to them, and then to get that information very quickly back to those clinicians that will be at the hospital. Paper's not a great medium for this. We heard Tiffany relate earlier how, you know, that was really a struggle for both the agency and the hospitals. And certainly the COVID crisis has emphasized that even more, because we don't want the EMS crews in the hospital any longer than necessary in order to transfer the patient to the care at the hospital. One other challenge that both Carilion Clinic as well as health systems around the United States have realized is that those patient care reports don't reliably make it to the patient chart quickly. As many as 50% of those documents don't make it all the way to the chart. And then that forces both the EMS agency and the hospital to get back together again via phone calls and faxes and manual processes. So the key for the health system was to be able to prioritize this particular initiative as to how much work effort it would take and what the return would be. And for Carilion, it was set forward as a goal to get accomplished and completed. If we look at the statistics that Carilion represents in terms of the community that they serve, you know, we think of it, we hear the name Carilion Clinic. It's not just a clinic. This is a large health system. They've got all these clinics. They serve over 1 million or about 1 million of their patients in this Southwest Virginia area, and they utilize Epic as their EHR. You can see all the various statistics that are here as to what they do, and you notice the ED visits. So a lot of those ED visits are initiated because of a transport to the hospital by an EMS agency. And so it's just purely a transactional thing. How many times are we having to touch this paper, getting it from one electronic system to another electronic system and to take care of this patient? And Care Everywhere then ends up being a component within Epic that facilitated this project to be completed very quickly. And you can imagine how many different connections it would take between all of their hospital locations as well as the EMS agencies that transport into those locations. So if we look at this next slide, we'll see where those particular hospitals or emergency rooms were located throughout this Southwest Virginia area. And you'll notice that they're separated by some distance. In many cases, if you look at Roanoke as kind of home office there for Carilion, then you've got Tazewell is 120 miles to the west, and we have all of these different agencies then that support each of these emergency departments and bring patients to them. And if we then look at the next slide, we'll see that we've got a number of agencies that are in these geographic areas transporting to Carilion Clinic. Actually, as represented here, this is how they are all licensed through ImageTrend for the ePCR system. And in total, there's 10 agencies that are using this method now of communicating the information into Carilion Clinic when they transport a patient. This represents these 10 agencies transporting over 1,000 patients per month to these facilities. And the beauty of this was once you're connected to Carilion Clinic, all we needed was the one connection, because through Care Everywhere then, all of this information through their Epic instance is now available to everyone within the community of Carilion. So with that, we made it very simple, and we'll want to have Michael walk through how those electronic pre-hospital patient care reports make it so quickly and easily into Epic.
Yeah, so let's talk a little bit about from Walt's perspective and the hospital's perspective, if their plan and their evaluation of how they went into this project and some details behind it to give you some perspective on the things that they were thinking about and why they chose the certain methods that they did. So the first thing of evaluating something like this about data exchanges between systems is uncovering the solution, right? So how are you going to do this? Well, the nice thing again is Carilion already was using direct secure messaging. So from other folks and other medical records coming in and out of their facilities, the obvious choice was to use that same methodology, that same technology, of applying that to EMS and pre-hospital systems, right? So, because it's the most efficient way that you can do it, right? Just reuse something that's already available, that you're already using, that you already know about. So from the solution standpoint, that kind of stuck out to them about what they should use for the technology side of things. The second piece that they were looking into is really identifying the community, right? Who is all of those EMS agencies that are transferring patients to their hospitals, right? Again, so what they uncovered is many of those EMS agencies were using ImageTrend Elite ePCR system, right, which is integrated with No2's direct messaging capability. So putting that together from what they're going to use to what the community looks like too and what the capabilities are, those pieces start coming together. The third piece was really enabling that technology, right? So we'll talk about this a lot, about how to enable or again, flip that switch on for all of these organizations, again, to be able to use that same methodology, that same secure direct messaging about sending those ePCRs in a CDA document directly to the hospital. So again, with all of those systems that had that technology ready to go on hand, flipping that switch was pretty easy. So again, the next thing that you do, and really the last step, is perform that testing. So when we talk about EMS, and about utilizing what they have in place, it was really setting up those accounts within No2 to give those EMS agencies a direct message and be able to just test a patient going through the full process of documentation of a patient, and then be able to send that data directly through to secure direct messages and being consumable by the hospital. And once that was in place, which was pretty easy, sending that test message, you know that it works, you know that the technology works already for other organizations. And once that was done, we're ready to go. So when you think about the next step of implementation, you take all those pieces together and you have all of those already enabled. The implementation was pretty straightforward. It really took less than a month to connect all of those agencies. Remember, Dane talked about that there's a lot of EMS agencies around that area that deliver to Carilion Clinic. So enabling them was pretty straightforward. And again, using direct messaging securely, right? We weren't we didn't have to go through some of the other steps that we have to go to if we're looking at doing an HL7 v2 message, meaning that no interface options, no VPN was needed. In our experience, sometimes it takes a month to just do the exchange of VPN spreadsheets and get that connection started just for the VPN and not flowing data. Where in this implementation, because we're looking at using what we did with these exchange methods, we were able to expedite that, which again goes to reducing those costs, reducing that effort about just doing the implementation part of it. So that was pretty straightforward and pretty fun to do. So now let's kind of do a deep dive into the use case for EMS. So I'll kind of talk about how EMS documents and how that data actually flows into Epic at Carilion. So like I mentioned before, on the EMS side of things, crews that are dispatched in 911 calls, they're doing their documentation in an ePCR. So they're using image training ePCR to do their documentation. So there's a lot of things that they're filling out, from provider impressions to medications to procedures that they're doing, all at the patient side and on transport to the hospital. So when you think about using the documentation system in EMS, it doesn't necessarily transfer easily to hospital-based methods, although it's getting better. So capturing all of that EMS data for that encounter for that patient, it comes together in that ePCR. And then what we do is bundle that information up and send it via secure direct messaging, where we're actually transforming that EMS data into a CCDA document with a PDF and transferring that over to the hospital system. So it has obviously that metadata for patient demographics, and then also including the rest of that ePCR encounter as well. So on the transferring side, we're sending that over to a direct address, and that's obviously being consumed on Carilion's side. It's going into Epic's Care Everywhere, so intrinsically, it's already using that metadata for patient demographic matching to identify which patient medical record already exists, and then ingesting that into the Epic system. So again, looking at this whole automated process, and what Tiffany described before about hooking up to printers or faxing or handing over paper, what this accomplished was automating the whole process. So from the EMS side of things, they're not having to hooking up with a printer. They don't have to do anything different. All of this is automated behind the scenes, from being sent out to being consumed on the hospital side. So from the holistic standpoint of it, sounds pretty simple, and that's what it is, and that's really what it comes down to. So really the goal was to improve the connectivity and efficiency on the exchange of information from EMS to hospitals. So I'm going to let Tiffany talk about the benefits that are realized from taking this kind of manual process and automating it.
All right, thank you, Michael. And so one of the biggest things, the providers in the field, those writing the reports, they realized the benefits immediately. They really didn't have to do anything additional. It just worked. And I had to laugh when I was asked to speak today because I didn't know what you wanted me to say, because it truly just worked. You spoke about taking no more than a month to set it up. It truly didn't. And on my part from Roanoke Fire EMS, possibly 3 days total is all it took. And that was just doing a test here, a test there. And then we put all the pieces together, tested one final time, and it just worked. So as soon as, a couple of the huge things that we did realize immediately, as soon as the providers wrote their report and they posted within the mobile version of ImageTrend, they hit that post button and the reports were uploaded. They were already familiar with that function. They already did that step. So there was nothing new they had to do. At that step, once they hit post, it automatically went to our billing provider, and it automatically went to the hospital. That was it. So we removed multiple steps from the providers. It was that easy. Let's see, there were multiple cost savings realized. We had no printer cost. We had a huge reduction in paper. Each PPCR, patient care report, you've got multiple pages of paper for that. And then you've got all the agencies going to Roanoke Memorial and hospital. So you've got thousands of pages of paper that are being shuffled around between our agency printing and the hospital printing and the providers printing. pretty much all of that got eliminated right off the bat. Time savings was realized because I was not having to go out to the hospital to troubleshoot the printers, the USB, the wireless connections. I'm at an office several miles away. I don't have to drive over there to go check on anything. All they have to do is hit post. They can actually do that driving down the road from the hospital, and the report will automatically go in. So our providers are getting back into the field more quickly, especially now. Michael, you spoke about, with COVID-19 going on, we need to get people out of the hospital as quickly as possible. One, we want them back out on the road to be able to take another call, but also we want to limit our time in the hospital and exposure. So, before they had to sit there and finish their report, while they're sitting there in the hospital, before they could leave to make sure the hospital got a copy, they get that copy immediately, even if it's when they're pulling out of the parking lot, or you've got the driver and then the passenger is finishing up the report, putting their narrative in, they hit post, within a couple of minutes, the hospital's got that report. Let's see. You had mentioned 93% of the reports are automatically matched once we post and they go to the hospital, but 100% of our reports that we're posting are also going to the hospital. So that is a huge benefit to us. We don't have to track those reports down. Every now and then there will be a report that our provider did not send over for some reason, or maybe he got another call and forgot to complete the first one, but those are few and far between. But 100% of what our folks are posting are going to the hospital. I think overall, it eliminated steps for the provider. It eliminated steps for me. There's only 1 or 2 steps that we've got to do, and it's so minimal, and truly it just worked. So at this point, I'm going to turn it back over to you, Michael, and talk about lessons learned.
All right. Yeah. So obviously, with any project, there's always takeaways that you can learn from it. So I'm going to go over a couple of lessons learned with this particular project, and hopefully, get you thinking about doing a project similar at your organization. There's just things that you need to think about. So the first one is really determining how to handle those patients that are Jane Does or John Does, right? So unlike other healthcare practitioners where there's really no pre-registration of patients, and obviously a number of times when EMS is called out, they may be called out to unconscious patients. You don't know anything about them, right? So there's not always that you'll be able to get that demographic information because EMS is with the patients in minutes, not hours in most cases. So one thing is just understanding that there are some that you're going to have to do a manual match, but again, using standards and like typical records exchanges too, if there isn't a match, it will go into a queue and it will require some manual intervention on that. But like Tiffany mentioned, what Carilion Clinic saw was 93% patient matching, right? So you think all of those automated processes before, and you're just dealing with a very small percentage of patients that you'd have to manually match. But it is there and something to take into account. The second piece is just education to both EMS and your agency, EMS agencies and the hospital staff. Again, Tiffany mentioned too, there was a workflow change, right? But a workflow change for the better, right? Less steps to do, less manual steps to do, but there is an education standpoint as well, as when you automate the whole thing, right? You want to make sure that people are comfortable and reduce any anxiety that they have to say, well, did my ePCR actually make it to the hospital? If I was printing it out before, I could actually physically, give it to somebody and hand it over to say, yep, they got it. So automating that process, there is an education point on both sides to say, you don't have to do these things anymore. This is where that electronic record is going to be placed. Not a heavy lift, but just something that you have to take into account to make sure everybody's comfortable and understands what the workflow has changed and why it's changed for the better. The third piece is really performing that outreach to other agencies, right? We've did a project, it was successful, and you really want to perform that outreach to say, is there any other locations, organizations that we can bring this to, right? You want to replicate what you're able to do, again, to reduce any manual steps, reduce any costs, and to increase patient care efficiencies across the board. So those are kind of the lessons learned of this project. So let's talk about next steps, because this was important too, as we went through the project and Carilion went through the project in all the EMS agencies. The one thing was getting to a point where we were today, but really visioning out what next steps could be and what are the possibilities of taking what was there and leveraging what we've put in place for being able to push data exchange or push data via exchange method, which is the common workflow for between EMS and hospitals. It's just that the one way of I've documented a patient care report and I'm giving it to the hospital. But what are those other healthcare standards and connectivity methods that we can take advantage to actually bring this further? So that's what we'll go into next. So we kind of talked about before the EMS use case about packaging it up and delivering it to the hospital. So the next piece we want to talk about is how we expand that, and how do we expand that with other industry standards. And the one thing that we want to talk about is using the care quality standard to do more information sharing. Again, based on these interoperability standards that are in place today. So there's two big pieces I want to talk about or call out, and really it's the two query methods. One is treatment and one is operations. So I'll start with the treatment query and why it's important. Again, with direct trust and moving that direct messaging, we were getting data from EMS to the hospital, right? Critical information for the hospitals to know about what happened in the field, about what was done with the patient, their impressions, the procedures and medications that were given, so they can treat that patient in the ED and then in their hospital stay. Well, equally important is having information for patients into the fields of medics that are on scene. So think about from an EMS standpoint, if I knew what the overview of a patient's medical record was, why I was treating them in the field, think about how important that would be. So as I'm treating that person, and obviously I know I need to know who they are, and maybe I swipe their scan to their driver's license so I know who they are, or they're conscious so they told me, and I was able to look up their medical record in the field, and I was able to bring back, and then I knew that they were a diabetic, or I knew they had COPD. Maybe I could treat them a little bit differently instead of just going in with my impression about what they are, or what conditions that they have. So using the treatment query, we're able to actually bring that information into the hands within their ePCR and be able to show the medic, this is what the patient's medical record is. We're actually able to import current medications, or actually we're able to verify and then import the patient's current medications, their allergies, their past medical history, access any care plans that they have. So it gives more information to the crew member that's in the field treating that patient, as well as saving time on documentation. Right, if I can just import that data in. So that being able to see that information on scene for the crew member that's treating that patient is huge. It gives them that whole perspective that they don't know, or they may not know right off the bat. The second piece is looking at the operations query. So another big aspect of EMS and treating a patient in the field and then rushing to the hospital and doing that patient handoff, there's the question about the care that I gave in the field. How did that affect the patient's outcome from the hospital? So, EMS really doesn't, unless they're proactively in going back to the hospital, say, what happened to this patient? What was their outcome? EMS really doesn't know that. So using the operations query, what we're able to do is pull back discharge summary information, meaning how long were they in stay in the hospital, what were they diagnosed with, what procedures were done, and then we're able to bring that information back and mirror that up to the EMS record. So now when you think of QA or CQI, or for education or training purposes, EMS is able to see what were we treated the patient for, what was the diagnosis of the hospital, is it spot on, is there anything that we need to change in our protocols, and it's just information back to EMS and the crew that treated that patient to really know what the outcome of that patient was. So there's a lot of key information that is available and that needs to be shared back and forth between EMS and hospitals, because that's how patient care gets better. You really have getting that data to be able to have that knowledge, write reports on it, do analytics on it, to really say, how can we maybe change stuff, or we know that we're doing good. There's nothing that we need to change, but you don't know that without data. And that's really what it gets us. The second piece of the query operation is payer information. So obviously EMS has a large operating cost for what they need to do and provide to the community, and in everything that they support too. So a big piece of that is getting up-to-date insurance and payer information for that patient so they can get reimbursed. Obviously dealing with unconscious patients and not being able to get that in the field and rushing to the hospital, there's not always time to get that or a way to get that. So again, hospitals hold that key to that data, and being able to share that back and forth enables EMS to better operate from a revenue recovery standpoint as well. So that was kind of the overview of the next level. And here's a quote from Walt, kind of talking about that. Because when we went into the project and we started doing this, one of the things is, and the great things is that the wheels started turning to say, this was great, how can we make it better? So when we think about expanding that out, that's one of the things that he was looking for, and that we started talking about, is how do we bring this to the next level? So a great quote from Walt. So now what I'm going to do is turn it over to Alan from No2 and talk about some observations about interoperability in general and about this use case.
Great, thanks, Michael. So I get to wrap us up a bit here, as Michael said, and kind of summarize some of the observations and a lot of what we've discussed here throughout the presentation. So there are two big sides to the discussion when we're talking to hospitals to get this connectivity in place. There's the IT side, and there's the clinical/workflow side. Leveraging standards that the EHRs already support, namely direct messaging and query-based record exchange through Carry Quality and Commonwealth, we're able to avoid the need for one-off point-to-point connections, and instead connect through the methods that the hospital EHR already supports and tie into existing workflows used for other interoperable exchange, all requiring very little, if any, work to actually connect. On the next slide here, you're all aware of the Meaningful Use, or now Promoting Interoperability program, and the amount of money that has been spent toward driving electronic medical record technology. What that means is that approximately 95% of hospitals in the country now have support for direct messaging. Now, admittedly, some are better than others, but support for direct messaging is widespread today. However, we are still seeing a year after year increase in the number of fax pages being sent in healthcare. Currently more than 10 billion pages per year. And much of that fax volume could be eliminated by better use of direct messaging, such as Carilion and their surrounding EMS agencies are doing, to get the documents straight into the hospital EHR and improve ease of processing. Direct messaging also makes this whole process scalable. Today we've been talking about one health system with a single EHR across all of their hospitals and a handful of EMS agencies that deliver patients to those hospitals. But across the country, there are 5,700 hospitals and 18,000 EMS agencies that can apply this same use case. We know the hospitals likely have the capability to use the direct standard, and when the agencies have it too, like Tiffany talked about, it's simply a test message away from working. Now, expanding beyond just EMS, there are skilled nursing, hospice, home health, therapy, behavioral health, ambulatory, vision. The concept is the same no matter who we're talking about. On the left side of the slide here, we just need to drive awareness to end users on what they already have the ability to do, enable that connectivity where it's lacking, and leverage existing healthcare interoperability standards like direct messaging for the exchange of patient information and eliminate all of those faxes. Now with that, I will hand it over to Direct Trust to facilitate some Q&A.